Hello everybody, welcome all to all judges, mentors, and actually presenting students. First of all, happy 77th Independence Day, and let us start and be in time. Present nicely. Do not take pressure. Best of luck to all. I request Shriya Mashekar to share the screen, and rest all please keep muted, and we'll start the presentation.
So is it visible?
Yes.
Yeah.
Yes, yes,
Hello everyone,
yes.
my topic is ophthalmic viscoelastic devices. So the learning objectives are to know what are OVDs, their properties, classification, uses, and the complications of using such OVDs. So what are OVDs? Viscoelastics are transparent gel-like substances which have a dual nature of viscosity of a fluid and elasticity of a gel or solid. So the properties can be spoken under viscosity, elasticity, cohesiveness or dispersiveness, and pseudoplasticity. So viscosity is the resistance of flow in a solution. When we compare water and honey is more viscous. Usually, higher molecular weight substances are more viscous. Such solutions tend to stay in the anterior chamber in the case of OVDs. Elasticity is the ability of a substance to return to its original shape after being deformed. Pseudoplasticity is the solution's ability to transform from a gel-like state into a liquid-like state under pressure. That is, their viscosity reduces under pressure. So such a property enables easy injection and removal of the OVD. Cohesiveness is the degree to which molecules adhere to like molecules. As we can see, the photograph shows a coin with the cohesive OVD on the right-hand side. And usually they're held together, and so they tend to form a bubble inside. This is how the cohesive property is helping the OVD to form the anterior chamber. CDI ratio is the one which gives you an idea of how cohesive or dispersive the OVD is. More than 30 is usually the property which explains cohesive OVDs. Coatability, usually lower surface tension and lower contact angles, and OVDs having more negatively charged have better coating ability, such as HPMC and chondroitin sulfate. So OVDs are a spectrum ranging from cohesive to dispersive. But for the ease of understanding, we will classify them under three headings: cohesive, dispersive, and viscoadaptive. Cohesive are usually high molecular weight, long chain chemical compounds. They have higher viscosity, higher pseudoplasticity, and hence create and maintain space and are easy to remove at the end of a surgery. The chemical formula of these are sodium hyaluronate. Examples are Helon and Helon GV. Whereas dispersive OVDs are lower molecular weight, short chain chemical compounds. They have lower viscosity, lower pseudoplasticity, and hence a higher coatability. So they adhere to external surfaces and stay inside the anterior chamber during fluidic movements, and hence are even difficult to remove at the end of a surgery. The chemical formula of which are usually HPMC, chondroitin sulfate, and examples are Viscoat and Endocoat. The last one, for ease of understanding, is viscoadaptive. These are long chain molecules which have fragile chains. So at low flow rate, they are highly viscous and behave like cohesive OVDs. But at high flow rates, they behave like dispersive OVDs because of fracturability of the long chains. Example being Helon 5. So at zero shear rate, that is when the fluid movement is very low in the anterior chamber, cohesive OVDs behave like jellies and tend to occupy space, whereas dispersive OVDs coat the endothelium and spread out. At higher shear rates, such as irrigation and aspiration, cohesive OVDs behave like spaghetti pasta. Once you try to remove one noodle, the long chains are entangled and are removed as a complete bolus, whereas dispersive OVDs behave like separate pieces of pasta, like penne pasta, and are difficult to remove. So the uses of OVDs. Cohesive OVDs can be used for capsulorhexis, IOL implantation, in patients having floppy iris syndrome, and to break the posterior synechiae, as they tend to occupy space and maintain it. Dispersive OVDs are used in lower endothelial count patients and dense cataracts to protect the endothelium of the cornea. Viscoadaptive OVDs give best of both worlds. Other than cataract surgery, it can be used in posterior chamber surgery, trabeculectomy, strabismus surgery, and canalicular tear repair. A special mention for the soft shell viscoelastic given by Dr. Arshanov before viscoelastics, which are adaptive, were introduced. He used dispersive and cohesive OVDs because it gave protection for the endothelium and it maintained space. The complications of using OVDs are most commonly post-operative IOP rise, usually starts within 6 to 24 hours post-operatively and is mostly seen in dispersive OVDs such as viscoat, but it resolves within 3 days after the surgery. The second one being capsular block syndrome. As we can see in the slit lamp picture, the Purkinje image between the lens and the capsule is thickened. This is before the treatment, and the treatment for this situation is yak capsulotomy. This releases the OVD that is entrapped behind the IOL and between the bag. Another complication is calcific band keratopathy because of phosphate buffers that is present in OVDs. And the last one is pseudo.
Hello. Just to interrupt, you have crossed the limit of 4 minutes now.
Yes, sir. The last one being pseudo anterior uveitis is because we see suspended RBCs in the anterior chamber post-op, which may appear as anterior uveitis is because of the viscosity of OVDs used, which can be left behind. Thank you.
So now judges can ask the questions on this topic.
You can stop sharing your screen.
You'd be comfortable using a soft shell technique vis-a-vis using a mixed cohesive dispersive OVD?
Ma'am, soft shell.
Why would you be more comfortable using a soft shell technique, and where would you really want to use it?
Ma'am, soft shell technique comparing to visco-adaptive because we can use both of them separately whenever required. As in, most people that I have seen, that is Dr. Uday Devgan or our institute, they use dispersive OVDs for the ease of removal at the end of surgery. But if we have both of them, that is cohesive and dispersive, but when we require them in difficult surgery such as shallow AC or with posterior synechiae, we can specifically use the cohesive OVD to form that space or break that synechiae. So we can get both of them separately when needed and soft shell when we need to use such as IOL implantation or during capsulorhexis.
Do you really need to use soft shell in all cases where you want to do a cataract extraction, where you want to do a capsulorhexis and an IOL implantation?
No, ma'am.
No, ma'am. So that is not really the technique that you will use always. When is
See, it's gone. Sorry, ma'am.
When would you specifically want to use a soft shell?
Ma'am, in shallow ACs with patients having and in pediatric cataract surgery cases where the capsule is elastic and there's low sterile rigidity. So we would want to form that space tightly so that the rhexis is in control at all times.
Can we go to next presentation?
Yes.
Yes. So, Dr. Pratiksha, please share your screen. Please start the presentation. Hello, Dr. Pratiksha. Hello. Dr. Pratiksha.
I think probably she has to
Please
unmute
start
herself.
your presentation.
Pratiksha, can you hear us? We can't hear you. You are muted or there is some problem with your mic. Can you try increasing the volume of your laptop? Should we move on to the next one? We can probably come
Yes,
back to
yes,
her at the
that
end.
is better.
Yes.
Yeah.
Yes, yes.
So can the
So
administrator stop the
we'll go.
timer? Reset the timer? Yeah.
Yes, yes. So please, Dr. Sri Lakshmi Pillai, share
Dr.
your
Pratiksha,
screen.
please stop sharing your screen.
Dr. Sri Lakshmi Pillai, please share your screen. Hello. Start presentation. Timer. Yes.
Can I?
Please start.
Hello.
Yeah. Yes, sir. Good afternoon, everyone. I'm Dr. Sri Lakshmi Pillai here from Bharati Vidyapeeth Medical College, Sangli. The topic is contraindications of laser refractive procedures. Coming to the basics, cornea is the chief refractive surface of the eye and is approximately 550 microns thick in the center, and it goes approximately 700 microns in the periphery with an average dioptric power of plus 44. Laser refractive surgery essentially consists of a spectrum of procedures aimed at modifying the refractive power of the eye, changing the corneal curvature using lasers. My topic is contraindications of these laser refractive surgeries, and I've tried to incorporate a small mnemonic for easy memorization of the same. Karan Arjun did not do physical training regularly. Coming to the full form of each of these: K for keratoconus or corneal surface disorders, A for age, drugs, diseases, pregnancy, thickness of the cornea, that is pachymetry, and refractive stability. Moving to the first one, age. Between 18 and 21 years, it is considered as a relative contraindication for corneal refractive surgeries, whereas below 18 years, it is an absolute contraindication. Next is corneal surface disorders. Absolute contraindications are keratoconus, some corneal dystrophies, and severe dry eye. Whereas conditions like patients with a history of herpes zoster keratitis or varicella zoster keratitis, they can go ahead with the surgery with preoperatively taking prophylaxis with an oral antiviral. Next is in certain systemic diseases like autoimmune diseases, like in case of Sjogren syndrome, the patient already has dry eye, and so it is contraindicated for laser refractive surgeries. Also, relative contraindication is a patient with diabetes mellitus. Diabetic patients have a risk of slow healing, and patients with uncontrolled diabetes have a high risk of infection. Coming to the next contraindication, patients who are experiencing fluctuating hormones, that is in condition of pregnancy and lactation, corneal thickness has been shown to increase during pregnancy, and hence these surgeries are avoided as it can improperly change the shape of the cornea. Then refractive stability should be achieved. That is, the power of the refractive error should be stable at least for a period of more than 1 year. Then coming to pachymetry, insufficient corneal tissue for the proposed ablation depth is an absolute contraindication. A preoperative pachymetry limit of 470 micrometers and a residual stromal thickness of more than 300 micrometers is required. Then certain systemic medications like amiodarone, isotretinoin, colchicine, and levonorgestrel are also contraindicated. The first one, amiodarone, it is an antiarrhythmic and it can cause cornea verticillata post-surgery. Isotretinoin is used
in the treatment of juvenile acne. It can also cause ocular symptoms such as dry eye, conjunctivitis, and blepharitis. And hence, isotretinoin should be discontinued for at least a period of 6 months before opting for any corneal laser surgeries. Colchicine has been reported to cause damage to ganglion cells, which may lead to flattening of the cornea, and hence, laser refractive surgeries are not recommended. These are my references. Thank you.
Thank you for completing in time. And the topic is open for the questions from the judges.
Yes, sir. Thank you, sir.
You can stop sharing the screen.
Hello.
Yes, sir.
Can you label a condition where it's not possible to do LASIK, specific ocular condition?
Ready? Next.
Specific ocular condition, sir. So when the patient has dry eye.
Yeah, of course, that you have already mentioned.
Yes, sir.
I'm talking about a condition which you have not mentioned.
Yeah, Ishwarya. Yeah.
The patient cannot keep his eyes stable.
It's a nystagmus.
Yeah, you cannot do LASIK in nystagmus. Okay, you have presented it quite well.
Thank you, sir.
Thank you. Thank you.
Thank you,
So
sir.
if no question, can we move to next? From judges?
Yeah, we can move to next
Yes.
presentation.
Okay. So Dr. Aishwarya, please
Yes,
share your
sir.
screen.
Yes, sir. Can I start, sir?
Yes, yes.
Yes, yes.
Just
Timer.
one sec. The timer.
Timer.
Yeah.
Good afternoon,
Start,
everyone,
please.
and a very happy Independence Day to all of us. I am Dr. Aishwarya Pandrikar. My topic for today is optic disc examination and glaucoma. Glaucoma is defined as heterogeneous group of disorders which manifest as chronic progressive optic neuropathy characterized by specific morphological changes at the optic nerve head and the retinal nerve fiber layer with the resultant loss of retinal ganglion cells resulting in the loss of visual fields. The main diagnosis the main diagnosis of the glaucoma is based on three main features: the intraocular pressure, optic disc evaluation, and the visual field changes. The various techniques used for the optic disc examination includes qualitative as well as quantitative assessment. Qualitative assessment includes direct ophthalmoscopy, indirect ophthalmoscopy, slit lamp biomicroscopy using 90, 78, and 60 diopter lens, and fundus camera photography. Whereas quantitative assessment can be done using confocal scanning laser tomography, scanning laser polarimetry, optic coherence tomography. Moving forward, in a normal optic nerve head, the NRR, neuroretinal rim, is the orange-pink tissue between the outer edge of the cup and the optic disc margin. As we can see in the picture, the inferior rim is the broadest, followed by the superior, nasal, and temporal rim. This is known as the Isn't rule. Moving forward, the cup disc ratio indicates the diameter of the cup expressed as a fraction of the diameter of the disc. The vertical rather than horizontal ratio is generally taken. As a basic principle, small discs have smaller cup and the larger discs have large cup. The optic disc size is an important factor in deciding the CD ratio and is also a prognostic indicator. It varies between the racial group and is largest in Africans. Normal median vertical diameter is 1.5 to 1.7 mm in a white population. Glaucomatous damage results in the characteristic signs involving the optic nerve head, the peripapillary area, and the retinal nerve fiber. The pathological cupping in the optic nerve head is caused by an irreversible decrease in the number of nerve fibers, glial cells, and blood vessels. A documented increase in the cup size is always significant. We usually get to see four distinct optic disc phenotypes in glaucoma, It includes focal ischemic optic disc, myopic optic disc, senile sclerotic optic disc, and the concentrically enlarged optic disc, which is usually associated with diffuse visual field loss. Moving towards the sign of glaucomatous damage, it can be classified into early signs and late signs. Early sign includes enlargement of cup, splinter hemorrhage at disc margin, discrepancy in the cup disc ratio in both the eyes of 0.2 or more, notching of NRR, pallor of NRR, loss of isn't rule, retinal nerve fiber loss. Whereas the late signs include enlargement of the CD ratio to 0.7 or more, as we can see in the picture, laminar dot sign, the gray dot seen in the cup, the bean pot cupping, nasal shifting of vessels, barring of the circumlinear blood vessels, bayoneting, and collaterals, development of collaterals. Going in little details of few of them, the disc hemorrhages, they often extend from the NRR onto the retina, most commonly seen inferotemporally, and it is a characteristic sign most commonly seen in normal tension glaucoma. Bayoneting refers to the double angulation of the blood vessel, as you can see in the picture. The barring of circumlinear vessels is a sign of early thinning of the NRR. The space between the neuroretinal rim and the superficial blood vessel. The laminar dot sign is usually seen in the advancing glaucoma. Gray dot-like fenestration in the lamina cribrosa become exposed as the NRR recedes. Moving forward towards the peripapillary area, the peripapillary area have usually two zones, the outer alpha zone and the inner beta zone. The outer alpha zone is characterized by superficial retinal pigment epithelial changes. The beta inner zone is characterized by chorioretinal atrophy. The beta zone is larger and more common in glaucoma and is a risk factor for progression. Quickly seeing the retinal nerve fiber layer defects. These defects are commonly seen, most easily seen in the red-free light. They could be either localized wedge-shaped defects or diffuse defects which have larger and indistinct borders. They often follow disc hemorrhages and they highly correlate with the visual field defects and the lost neural rim tissue. The following slide summarizes all the optic disc changes we just discussed. Thank you. These are my references.
So thank you, Dr. Aishwarya. You have just crossed 2 seconds time limit, so no problem.
Sorry, sir.
So hand over judges for asking questions.
I have two questions to ask you, Aishwarya. Can you hear me?
2 minutes, ma'am. Actually, I'm trying to stop my screen share.
Okay.
You can ask, madam. She
Okay,
can answer.
So the first thing is your first slide said that when you talk of glaucoma, you talk of the triad, the intraocular pressure, the
visual field defects,
and the optic nerve head defect. Have you realized that intraocular pressure is no longer a part of the definition of glaucoma?
Yes, ma'am.
So that is not really considered, because what happens to those who have normal tension glaucoma or ocular hypertension?
Yes, ma'am. I actually meant, ma'am, for monitoring the glaucoma, we usually, in all the follow-ups for patients, we look to for the IOP.
So that is a parameter that you look at, but that is not a sign of glaucoma.
Yes, ma'am. I should not have used the word diagnosis there.
Correct. That's
yes,
right.
ma'am.
And the second thing is that you were talking about the cup size in a very large way. Whereas in glaucoma, you could have, in no glaucoma, you could have big cups, large physiological cups. It is actually the neuroretinal rim that is more important than the cup size.
Yes, ma'am.
But you have laid a lot of stress on the cup size.
Okay. Yes,
so do
ma'am.
you think that you could have altered that a little bit?
Yes, ma'am.
And you've talked about the retinal nerve fiber layer defects. Normally, where are these retinal nerve fiber layer defects seen? You said more in the inferotemporal region, that I agree. But how would you know that this is a wedge defect that is talking about an RNFL loss?
Yes, ma'am.
What
ma'am,
is
RNFL?
Yeah, so where should that RNFL defect start from?
Ma'am, it is usually better seen in the red-free light.
No, it is seen, you identify it, all correct. But
okay,
where does it have to actually start from? From the edge of the disc.
Yes, ma'am.
It has to be a damage at that disc point, and from there, if you see an RNFL defect, then that is a glaucoma.
Yes, ma'am.
Thank you.
Thank you, ma'am. Thank you, sir.
So can we go for next presentation?
Yes, sir.
Yes. Dr. Nilambika, please share your screen. Dr. Nilambika.
Hello, is my screen visible?
Ready?
Yes.
Are you
One
ready to
minute.
start?
Just 1 minute, sir. I cannot see the timer actually. I'm unable to see the timer.
Yes. Timer, please.
Okay, okay. Okay. Yes, sir, I can see. Okay. So, good afternoon, class. Welcome to ophthalmology. And today's class is on corneal anatomy and its clinical significance. So, we all know that the cornea is transparent. It forms the anterior one-sixth of the fibrous coat of the eyeball. The anterior surface is elliptical in shape with the horizontal diameter being more than the vertical diameter. The shape of the cornea is such that centrally it is more steeper and the periphery is more flatter, which is called as being the prolate shaped, as opposed to being oblate shaped, where it is flatter in the center. Then we come to the thickness, which is thicker in the periphery and it is a little bit thinner in the central area. And the anterior surface, as we can know, the cornea contributes to about plus 43 diopters of the total refractive power of the eye, which is a very important point. So, like we just discussed in the previous session, in myopic patients, when we do laser refractive surgeries like LASIK and PRK, what we are trying to do is converting the prolate shaped cornea to a little bit of oblate shape. Other abnormalities with the cornea may be seen, the shape of the cornea, as in keratoconus, the keratoglobus, as well as cornea plana. Now let's cut open this cornea and look at it under the slide. What do we see? The different layers of cornea. We have 6 layers. The first being the corneal epithelium. It is a stratified squamous non-keratinized epithelium. The basal cells are columnar in shape and they are attached to each other with the help of desmosomes. This helps in the barrier function of these cells. So also there are presence of hemidesmosomes which attach these cells to the underlying basement membrane. When damaged, they may result in recurrent corneal erosions. So above these cells are the wing cells and the superficial cells with presence of apical microvilli which help in the stabilization of the tear film. The Bowman's membrane is merely a condensation of the anterior stroma. It is a resistant layer and it heals by scarring. Now this scarring is utilized when we do an anterior stromal puncture in cases of recurrent corneal erosions. So coming to stroma, which is the 90% of the thickness of the cornea, it is mainly composed of collagen type 1 fibers as well as cells like keratocytes. What we have is a parallel lattice-like regular arrangement of these cells are present. The diameters of these collagen fibers and the distance between them is regular and it space less than half the wavelength of the light, which helps in contributing to the transparency feature. So as in corneal edema, the distance increases, thus leading to loss of transparency. Coming to the Duas layer, which is the fourth layer, it is a strong and it does not extend to the periphery. Where might this be useful? When we dissect during the DALC surgery, we use a big bubble technique. The type 1 big bubble, which we want to achieve, is between the Duas layer and the stromal layer. Coming to the Descemet's membrane, which is the true basement membrane of the endothelial cell layer, and it has an elastic property and it is very resistant, having regenerative potential, and it ends in the Schwal-Base line. So if there is any a tear in the Descemet's membrane, we can see, and we can see the loss of elasticity. The innermost layer is the endothelial layer, which is a single cellular layer, and we have polygonal shaped cells with no regenerative potential. So if they are lost, they are lost. We can check them under a specular microscopy, and cell density less than 500 cells per mm² may lead to corneal decompensation. The blood supply, as we know that the cornea is avascular, it is achieved through the tear film, and the nerve supply is rich and it is from the branches of the long ciliary nerve. So this was all about cornea, and we will study the physiology in the next class. Thank you.
Thank you, Dr. Nilambika. So now the topic is open for questions from judges. Hello, any questions?
I think she has presented quite well. I don't have
Thank
any
you.
questions.
Okay, thank you. I think either the students have understood everything, so I think my job is done. Okay.
So
Thank you.
can we go to next presentation?
Yes, sir.
Yeah. Dr. Kishan, please share your screen. Dr. Kishan.
Yes, sir. Yes.
Are you ready to present?
Yes, sir.
So start.
Good
Please start.
afternoon, everyone. Look at this.
Your voice is not clear.
Yes. Clear, sir?
No, no.
Hello.
Your
Yeah, now
voice
it
is
is
not
clear.
clear.
Now
Sir.
it is clear.
Yes.
Okay, okay.
Okay, okay.
Can you reset the
I-
timer, please? Can the admin reset the timer? Yeah, you can start.
Hello, good afternoon, everyone. Look at the screen. What do you see? This is a case of macular hole. This is a case of the giant retinal tear. This is the case of the endophthalmitis, and this is the nucleus stroke. Now, what will you do? We will do pars plana vitrectomy, and after injecting the some vitreous substitute into the vitreous cavity. So today's our class is vitreous substitute. Ideal vitreous substitute is similar to the vitreous. So main vitreous substitute is maintain the IOP, transparency, and this is non-toxic to the eye. The vitreous substitute is two type, mainly the gas and the liquid. The gas is about the non-soluble biocompatibility, high buoyancy, and high surface tension. It is also be categorized as expansile and non-expansile gases. Now we will move on to the gases. The three type of gases is commonly used: air, C3F8, and SF6. Air is non-expansile gases, easily available, colorless, and it is absorbed by the circulation. So it is less tamponade to the retinal break or detachment. The refractive index is low, so this is a poor optical function after injecting the air. Now we will move on to the C3F8 and SF6. C3F8 and SF6 are heavier than the air, so it is used to pneumotoretinopexy, and it is good tamponade effect because of the high surface tension and slow diffusion. The concentration of C3F8 is 12%, and the concentration is 20% of SF6. This is the concentration is non-expansive gases. So I will explain one SF6 example. 0.5 ml SF6 into the vitreous cavity, and it is double over a period of the 36 hour, and it is stay into the vitreous cavity with 12 days. Similar like that C3 effect and air. After the post-operative patient, we will advise to supine position because of the tamponade is maintained, and avoid the flying and the scuba diving because of the increased expansion of the gases. Now we will move on to the liquid. PFCl is mainly high specific gravity and low surface tension due to flatten the retinal detachment and displace the subretinal fluid from the retina, and it is not longer in the vitreous cavity because of their toxicity. Now silicone oil is low specific gravity and high surface tension, so it is the good vitreous substitute to maintain the tamponade effect. And in clinically we can use viscosity around 1000 and 5000 centristone. Now we will move on to the complication. This is posterior subcapsular cataract. This is angle closure glaucoma, secondary angle closure glaucoma due to the silicone oil. The third is a band shape keratopathy. This is due to the silicone oil toxicity. And fourth is emulsification of the oil. Emulsification of oil due to the formation of the hypervolume. So we can remove this after long time. Heavy silicone oil and experimental study, you can. Thank you.
Any questions from the judges?
When would you prefer to use gas vis-a-vis a liquid in as a vitreous substitute?
We can't use nowadays.
What can you not use?
We can discuss in next class, students.
Hooray. That was great. That was a great answer.
Okay.
Okay, thank you.
Can we go for the next presentation?
Yes.
Yes.
Yes. Dr. Anusha, please share your screen. Are you ready to present? Anusha?
Yes, sir, I'm ready to present.
Yes. Timer, please.
I hope I'm
Start.
audible.
Yes, yes. Start, start.
Good afternoon, I'm Dr. Anusha Kumbhar, and I'll be presenting the topic dyes in ophthalmology. So dyes are important and valuable diagnostic and therapeutic tools. These are the commonly used dyes and stains which are used in ophthalmology. Vital staining is graded as pattern, position, depth, and grades. The first dye that we'll be discussing is about the fluorescein dye. It is available in the form of strips, which is impregnated with 0.6 milligram to 1 milligram of the dye, as well as IV injection preparations. It is orange in color, it is water soluble, and adheres to the basement membrane. It absorbs light in blue spectrum and emits light in yellow-green spectrum. It is used for staining the cornea in corneal epithelial defects, as well as various diseases such as keratitis, corneal ulcer. It is used to diagnose dry eye disease for tear film breakup time test and Sjogren's disease. It is used in Siedel's test to check the perforation or the leakage of the dye. It is also used in applanation tonometry, like Goldman's tonometry, Perkins tonometry, and to test the patency of nasolacrimal duct in Jones dye disappearance test. And it is used in fundus fluorescein angiography. Over here, the picture shows superotemporal branch retinal vein occlusion. The next dye that we'll be discussing is the rose Bengal dye. It is available as 1.3 milligram dye impregnated strips, and it stains dead and devitalized cells, including mucous strands on the ocular surface. So it is used for diagnosis of dry eye disease as well as HSV keratitis. It is actually highly ocular toxic, and it causes a lot of patient discomfort such as stinging and burning sensation. The next dye is lissamine green. It is also available in the form of the dye impregnated strips. It is acidic and it has a high affinity for staining dead and degenerated cells. So it is preferred dye for staining the bulbar conjunctiva in cases of Sjogren's syndrome, and also to ascertain the proper fitting of contact lens, like we can see in these pictures. The next dye is trypan blue dye. It is available as 0.06% vision blue, which stains the anterior capsule of the lens during cataract surgeries. Also as 0.15% membrane blue dye, which is used for staining for the posterior segment surgeries. The stain is also used to stain the Tennant's capsule after enucleation surgeries for layered closure. And it is also used to stain and strip the Descemet's membrane in Descemet stripping endothelial keratoplasty, as well as stripping the corneal endothelium for deep anterior lamellar keratoplasty. It is ready to use, and it is available in a pre-mixed solution in a disposable one-use glass syringe. And low doses do not produce any inflammation or corneal toxicity. But it has to be used with caution in pregnant and lactating women, as IV doses have been found to be teratogenic in animal models. The next dye is indocyanine green. It has high affinity for collagen type 4 and laminin, which is found in the internal limiting membrane. Hence, it is used in chromovitrectomy to visualize the internal limiting membrane. Also used for anterior capsular staining during cataract surgery and indocyanine green angiography to visualize the choroidal circulation. It is used as the dye gets washed out very quickly, and indocyanine green angiography is generally better tolerated than fundus fluorescein angiography. But the major disadvantage is the decomposition that occurs because it is chemically unstable. So it causes retinal toxicity. Over here, we can see the green stain internal limiting membrane and the indocyanine green angiography. The next stain is bromophenol blue. Brilliant blue. It is used for it has a high affinity for the internal limiting membrane. Without staining the epiretinal membrane, it is used in the chromovitrectomy surgeries as well as posterior segment surgeries. It is also used in preparation of Descemet's membrane graft.
Sorry for interruption. You have crossed the time limit.
The next dye is bromophenol blue.
Continue.
This dye shows high affinity for internal limiting membrane, and it is used in posterior segment surgeries. But there is comprehensive information which is less on preclinical and clinical safety on this specific stain. Also, patent blue dye.
I think you'll have to stop this thing because it's
Yes.
But it is
Anusha,
not.
Anusha, please stop presenting.
Hence, to summarize, these are the stains used in ophthalmology. Fluorescein dye, it is orange in color but stains green and stains cornea, and it is used for corneal ulcers, epithelial defects, Little's test, ear film breakup time, and fundus fluorescein angiography.
Okay. Please stop.
It's red.
Stop
Stains
sharing the screen.
used for dry
Doctor,
eye.
please stop sharing your screen.
Stop sharing.
It stains green, stains the conjunctiva, used for dry eye.
Anusha, please stop sharing.
Blue, anterior segment of the lens, the Descemet's membrane.
Dr. Anusha, please stop sharing.
Am I audible?
Please stop sharing.
Yes.
Sharing the screen. And if questions are asked, please answer them.
So between lissamine green and rose Bengal, which is the dye that you would prefer to use to look at conjunctival defects? And why?
Ma'am, I'm really sorry. I couldn't hear the question.
Between lissamine green and rose Bengal, which dye would you prefer to look for defects in the conjunctiva, and why?
Ma'am, I would like to use lissamine green as it causes less toxicity to the eye. It has less discomfort, and hence lissamine green.
Okay.
Any other question? So can we move to next?
Yes, sir.
Yes, we can proceed.
Okay. So, Dr. Rahul, share your screen.
Yes, sir. Am I audible?
Yes. Your screen is not visible. Yes. Can you start presenting? Ready for presentation?
Yes, sir.
Yes. Timer, please. Start.
Good afternoon. This is Dr. Rahul. Today I am presenting the topic of differential diagnosis of limbal mass. Limbal masses can be classified into following categories. First one is degenerative conditions like pingicula, early pterygium, and cystic pterygium. Inflammatory conditions are episcleritis, scleritis, Flichten, and vernal cataract. Tumors can be dermoid, lipodermoid, squamous cell carcinoma, and papilloma. Cysts can be congenital cystic lesions, lymphatic cysts, epithelial implantation cysts, and parasitic cysts. Miscellaneous can be foreign body at the limbus, intracalary staphyloма, and filtering bleb formed following the trabeculectomy surgery. In degenerative conditions, first one is pingicula. It is triangular yellowish patch near the limbus. It is due to hyaline infiltration with elastic degeneration of the subconjunctival tissue. It usually occurs in elderly, and treatment is excision for cosmetic purpose. Next one is pterygium. It is the triangular sheet of fibrovascular tissue invading the cornea. It is due to elastotic degeneration of the subconjunctival tissue. Treatment is excision with conjunctival autograft. Here we can see the pictures. First one is pingicula and second one is pterygium, and the last one is cystic pterygium. Next is inflammatory conditions. It has episcleritis and scleritis. Episcleritis is benign recurrent inflammation of the episclera involving the overlying Tenon's capsule. It is due to hypersensitivity reaction to endogenous and tubercular or streptococcal proteins. It is usually asymptomatic or sometimes mildly painful. Treatment is topical NSAIDs and mild corticosteroids. Scleritis, it refers to inflammation of the sclera proper. It is due to autoimmune disorder or any endogenous infections. Scleritis can be diffuse or nodular. Patient has moderate to severe pain. Treatment can be topical and systemic steroids can be used. And also treatment of the underlying cause should be done. The first picture is of the episcleritis and the second is of the scleritis. Next is flectanular keratoconjunctivitis. It is characterized by nodular flectin occurring as an allergic response of conjunctival and corneal epithelium to some endogenous allergens. It is also due to delayed hypersensitivity reaction to endogenous microbial proteins. Common causes can be staphylococcal proteins or tubercular proteins. Treatment is topical steroids and treatment of the underlying infection. Next is vernal catarrh. It is characterized by multiple small nodules near the limbus as shown in the picture. It is also due to hypersensitivity reaction to exogenous allergens such as pollens and dust. It commonly occurs in children and most common in summer. Treatment is mast cell stabilizer, steroids, and NSAID. Next is tumors. It can be classified into congenital tumors like dermoid and lipodermoid. Dermoid is common congenital tumor which usually occurs at limbus. Appears as solid white mass firmly attached to the cornea. It consists of collagenous connective tissue, sebaceous gland, hair lined by epidermoid epithelium. Treatment is simple excision. Next is lipodermoid. It is congenital tumor usually found at limbus. Appears as soft, yellowish, white, movable subconjunctival mass. It consists of soft tissue surrounding dermis-like connective tissue. It can sometimes be associated with golden hour syndrome. Golden hour syndrome is associated with presence of accessory auricles as shown in the picture, and some other congenital defects can also be present. Next is neoplastic conditions. They are papilloma, squamous cell carcinoma, and primary melanoma. Papilloma is a benign polypoid tumor, can be sessile or pedunculated. It can sometimes also. Treatment is surgical excision, and tissue biopsy should be sent for histopathologic examination. Next is squamous cell carcinoma. It is a flat granular growth. It is common at limbus, and it usually invades the underlying structure. It requires early excision. Next is primary melanoma. It is nodular form of malignant conjunctival melanoma, commonly arise at limbus. It may be pigmented or non-pigmented. Treatment is local excision. These are the miscellaneous causes of limbal mass, such as foreign body at the limbus, intercalary staphyloma, and retention cyst. Thank you.
Thank you, Rahul, for completing time. Now the topic is open for questions by judges. Stop sharing. Rahul, please stop sharing your screen.
Rahul, you can hear me?
Yes, sir.
Rahul, in the OPD, what one simple thing
Yes.
you can do to distinguish between episcleritis and scleritis in the OPD?
The branching test.
Yeah, what is that?
Sir, with the tropic acid.
Yes, you are right. Go ahead.
Episcleritis, it usually does not blanch, but the scleritis blanches due to deeper invasions.
Anybody wants to ask any question? More questions? Okay. Shall we move to next?
Yeah, I think we can move to the next
Okay.
one.
So, Dr. Kehekashan, please share your screen. Are you ready to start presentation?
Yes, sir.
Timer, please.
1 second.
Timer, please.
Okay, it's okay.
Start. Hello.
Good afternoon. The topic of my presentation. Hello. Hello. Sir, I'm audible. Hello. Hello.
Start. Yes,
You are
yes.
audible.
Please
Good
start.
afternoon.
Yes.
Good afternoon. The topic of my presentation is refraction in children. Before giving refraction in children, we have to categorize the child according to the age. The first important thing is the history taking. Then we have to look for the visual acuity. Then we have to look for the visual acuity, then ocular alignment, stereopsis, dry static and dynamic retinoscopy, and subjective refraction is done in older children. Decision making is based on the emmetropization, visual need and functional vision, and amyloidogenic potential. Here we can see the visual acuity assessment is different in different age groups. For infant, the child can fixate and follows light. For 1 to 2 years, we can use colored candies. For 2 to 3 years, we can use cardiac acuity cards or K-picture cards. For 3 to 5 years, we can use HOTV cards. And for 6 years and above, we can use Snellens
Your
or
slides
Longmark.
are not moving.
1 second,
You go on a
sir.
full screen mode.
Yes, sir. 1 second, sir. The entire screen.
You can
1
reshare.
second, sir. I'm trying to do that. Yes, sir. 1 second. Sir, now it's
Yeah, it's moving.
sir, it's moving. Good afternoon. Sir, shall I start from the start? Okay. Good afternoon. The topic of my
Just one
presentation
sec.
is
One sec.
refraction in
One sec.
children.
We'll have to reset the
We have
timer.
to retime you.
Okay. Yes, sir.
Admin, can you reset the timer, please? Yes, you can start now.
Good afternoon. The topic of my presentation is refraction in children. Before doing the refraction in children, we have to categorize the child according to the age. A thorough history taking is very important. Along with that, we have to see visual acuity, ocular alignment, stereopsis, dry static dynamic retinoscopy has to be done. Subjective refraction is done in older children. Decision making is done on the basis of emmetropization, visual needs and functional vision, and amyloidogenic potential. Here we can see the visual acuity assessment in different age groups. For infants, the child can fixate and follows light. For 1 to 2 years, we can use colored candies. For 2 to 3 years, we can use cardiac acuity charts or K-picture charts. For 3 to 5 years, we can use HOTV charts. And more than 6 years and above, we can use Snellens or Logmark charts. The choice of refraction is different in different age groups. For infants, we can use Mahindra retinoscopy or cycloplegic retinoscopy. For preschool and school-going children, we use cycloplegic retinoscopy and subjective refraction. The choice of cycloplegic is also different according to the age of the child. For younger child, we can use atropine sulfate. For older children, we can use cyclopentolate and tropicamide. In this video, we can see in retinoscopy, if the reflex is moving with the moment, then we have to add convex lenses, that are the plus lenses. If the reflex is moving against the moment, then we have to add concave lenses, that are the minus lenses. And if there is no movement of the reflex, it means that the point of neutralization has been reached. Now, in this slide, we can see the retinoscopic reading in a 6-year-old child with the cyclopentolate tropicamide. Here, the refractive error is shown at both the axes. Before giving the final correction, we have to take care of 2 points. We have to correct it for the working distance, and second one is the cycloplegic agent use. Here, we have done the retinoscopy at a working distance of 50 centimeter, and cyclopentolate and tropicamide is used. So we have to totally subtract 2.75 from the for getting the final correction. So we'll get the corrective values for both the eyes, and we can transpose it to the other axis also. Therefore, the decision for the refraction in children depends upon, is the refractive error within the normal range for the child's age? Will this error emmetropize or interfere with the normal visual development? Will prescribing the glasses improve the visual function or interfere with the normal process of emmetropization? Here we can see in myopic correction, it decreases the exotopias, whereas increases the esotopias. Whereas the hyperopic corrections decreases the esotopias and increases the exotopias. The myopic correction in infants, if it is more than -5 diopter, we have to correct it. And for children more than 3 years, if it is more than 1.5, we have to correct it. For hypermetropia in infants, if the error is less than 2 diopter, we have to monitor it, and if it is more than 2 diopter with esotopia, we have to fully correct it. For the refractive error 3 to 6 diopter without esotopia, we have to monitor it, and for more than 6 diopter without esotopia, we have to undercorrect it. We have to leave some amount of the refractive error that will act as a stimulus for the emmetropization. Now for 1 to 5 years, whatever the refractive error, if it is with esotopia, then we have to fully correct it. If it is less than 2 diopter without esotopia, we have to monitor it, and more than 2 diopter without esotopia, we have to undercorrect it. For the more than 5 years, whatever the refractive error, with esotopia, we have to give full correction, and without esotopia, we have to undercorrect it. For astigmatism, we have to correct it if it is equal or more than 1.5 diopter. Oblique astigmatism is very amblyogenic, so it should always be corrected. For anisometropia, if it is along with the amblyopia, the correction has to be done. For anisomyopia, full correction has to be done. And in case of anisohyperopia, we have to reduce corrections equally in each eye. Therefore, before giving the refraction in children, we have to consider some points according to the different age groups. In infants and toddlers, we have to consider all these points. For preschool children, we have to consider vision, amblyopia, symptoms, and family history. For school-going children, the most important are the vision and the symptoms. Thank you.
Hello, thank you for completing in time. Now the topic is open for questions from judges.
You talked
Any
about
questions from?
you talked about refraction error. You have given them the correct refraction error. How will you make sure that the child uses the glasses?
Sorry, ma'am. I couldn't hear the question.
You have prescribed a particular correction for a child. How will you ensure that the child
Yes,
will
ma'am.
continue to use the correction? But because just prescribing is not going to sort your problem out.
Yes, ma'am. Before giving the correction in the child, we always do cycloplegic correction because it is the best for the child, and we will try to will see the response of the child. If suppose we have given the good correction, and if we occlude one eye, he will not be irritable, and also we will call the parents for the regular follow-ups. We'll try to give the spectacles. We try to give the colorful spectacles to the children, because it will motivate the child to wear that spectacles, and also we'll call him for the regular follow-ups. For initially, we generally undercorrect it if there is the child is under 5 years of age. After that, we have to follow the child so that we can give full correction after the emmetropization has reached.
Thank you.
Can we go to next presentation?
Yes.
Dr. Afrit, please share your screen. Are you ready to start? Dr. Afrit, are you ready to start presentation? Are you ready?
Hello.
Yeah.
Yes. Are you ready to present, Dr. Afri?
Hello.
We can hear you.
Okay. Start presentation.
Yeah.
Timer, please. Timer.
A very
Yes,
good
you can
afternoon,
start.
everyone. I'm Dr. Afid Jaipuri. And before discussing new IOLs, let me introduce you to the enemy in chief for today's session, the spectacles. New IOLs are being developed to provide a presbyopic solution and to correct the pre-existing refractive error without the use of spectacles or contact lenses. The basic monofocal IOLs have no range of vision, whereas the newer multifocal and accommodative IOLs have the maximum range of vision. The EDOF IOLs are a middle ground between these two. Multifocal IOLs can be refractive optics or diffractive optics. The refractive optics multifocal IOLs have concentric rings of different powers. The bifocals or two-zone lenses have a central near vision segment of 2 mm, which is used for near vision, and a peripheral distant vision segment. The disadvantages of these lenses is that in bright sunlight, when the pupil constricts, the peripheral segment is occluded, and hence the distance vision is hampered. The annulus type or the bull's eye lens has a central segment for distant vision, the middle ring for near vision, and a peripheral ring for distance vision. While reading in bright light by using these lenses, the pupil constricts and may occlude the middle ring of near vision, and thus the near vision may be hampered. Diffractive optics multifocal IOLs have near and distance correction in each of the concentric rings using diffraction optics. They can be bifocal or trifocal. The bifocal IOLs have a monofocal IOL along with a diffractive cuneiform plate. The cuneiform plate has multiple ridges from center to periphery, which splits the light into different orders of rays. The zero order rays passes undeviated, and the first order rays bend towards the near focal point. If the height of the ridge is kept at half the wavelength of light, the light distribution is 40% for distance, 40% for near, and 20% of the light is lost. The width of the diffractive steps governs the near focal addition of the cuneiform segment. Narrower the width, greater the add. So this is the summary of bifocal diffractive lenses, where the monofocal lens focuses the light on the cornea, and the diffractive cuneiform plate splits it into different orders. The zero order rays are used for far vision, and the first order rays are used for near vision. The trifocal diffractive IOLs superimpose two bifocal cuneiforms over a monofocal IOL. Hence, they have three focal areas at distance, intermediate range, and near range. Drawbacks of diffractive IOLs include photophotic phenomena like halos and glares, because blur circles are caused by the unfocused light at the point where one set of rays comes to focus. They also cause a drop in contrast, and the scotopic vision is compromised since the light is split between the distance and near vision, and 20% of the light is lost. The extended depth of focal IOLs have one elongated focus, thus giving a larger range of vision. The Technis Symphony IOL uses diffractive estrate optics to provide extended range, but it has halos and glare. The Alcon Vivity IOL is a beam shaping IOL. It alters the wavefront of the central light beam coming into the eye, but it creates a loss of contrast. Crystallens HD is the only FDA approved accommodative IOL. It has a single aspheric monofocal optic, and it is a hinged IOL. It is designed to fold posteriorly against the capsule. This movement is dependent on the positive vitreous pressure to shift the lens forward. Advantages of this lens include that there are no halos or glare, and there is no loss of contrast. But it has the disadvantages that accommodative amplitude reduces with capsular opacification, and it depends on the strength of the ciliary muscle contraction, which wanes off with age. Presbyopic IOL technology continues to improve, and soon we'll be able to say no to glasses. Thank you.
Thank you, Dr. Afrid. Now the topic is open for the question from the judges. Any questions?
Afrid, can you hear me?
Yes, sir.
Afrid, without really mentioning or going into brands, can you tell me that suppose or whenever you are going to have a cataract surgery done, which lens would you recommend to yourself?
So myself, I am very okay with using spectacles as of now. So I won't be compromising my vision by halos or glares, and or loss of contrast or these phenomena. I'll be happily using presbyopic lenses. And it for different surgeons, it will be surgeon preference as of now, because there's no IOL which has only positives, and there are no drawbacks of any of the lenses. Even accommodative lenses have their own drawbacks. EDOF lenses have their own drawbacks. So it will actually depend on the patient and the patient's preference and the surgeon's preference.
So in today's world where everybody is so mobile friendly, would you not want to keep the patient at least a little happy in terms of not reading, maybe reading little papers or little words, but at least using their mobile or their computer very often?
Yes, ma'am.
With no
Definitely.
glasses?
If a patient comes to me with that requirement, I'll prefer the EDOF lenses, because in today's world, most of us hardly use any, have mostly shifted from books to laptops, iPads, and we require intermediate range of vision more than we require near vision range. So I'll be preferring EDOF lenses in those patients. But I just answered because sir asked which lens I would prefer for myself.
Thank you.
Okay, thank you. So we'll go to next presentation. Dr. Gargi, please share your screen.
Am I audible?
Yes, yes.
So my name is Dr.
Just,
Gargi Mohan, and I'll be
just,
presenting. Yeah. Should I start, sir?
yeah. Start.
So good morning, everyone. My name is Dr. Gargi Mohan, and I'll be presenting on topic biometry. So according to National Institute of Health, biometry is defined as the measurement of anatomical dimensions of the eye, which includes corneal curvature, axial length, and anterior chamber depth. For corneal curvature, the procedure that we perform to measure it is keratometry, and the machine that we use is the keratometer. We get the K1 and K2 reading, which are the flat and the steeper corneal curvatures. Second one is the axial length, which can be measured by A-scan biometry. As mentioned on the screen, it is of two types, ultrasound A-scan biometry and optical A-scan biometry. Ultrasound A-scan biometry uses a higher frequency sound waves, which are generated by a handheld probe to measure the axial length of the eye and the various internal structures. There are two types of ultrasound biometry. One is first is applanation A-scan biometry, and the second one is immersion A-scan. In the first image, we can say that the probe is held onto the hand, and it is placed on the cornea, which is a contact biometry. In order to prevent the manual error of putting excessive pressure or putting too lightly the probe on the eye, immersion A-scan biometry is done. Wherein you can see in the second image, we have used a scleral shell into which saline is put, and on that the probe tip is kept so that the corneal contact is nullified and the error is cancelled out. For accurate measurement of the axial length using applanation, we have to ensure that the machine is calibrated and set for the correct velocity setting depending upon the grading of the cataract. The echoes for cornea, anterior lens, posterior lens, and retina should be present and of good amplitude. For that, the gain should be set at lowest level for approximately 70 to 75%. But if the grading of cataract is more, we can increase this gain. Then do not push the probe too hard or place the probe too lightly, because it can alter the axial length recording. Then average 5 to 10 readings are to be considered, and with lowest standard deviation. Always measure both the eyes and repeat if the difference in both the eyes is greater than 0.3 mm. Optical biometry, as I already told, it is based on it uses infrared light, infrared rays of 820 nanometers. There are 3 machines into it, and all of them have different principles. For example, IOL Master is based on partial coherence interferometry. Lenstar is based on low coherence optical reflectometry, and IOL Master 700 is based on swept source OCT. So it provides an image-based measurement. Biometry is performed as a preoperative assessment for all the patients undergoing cataract surgery. And the measurement obtained are used for intraocular lens calculation. The most commonly used formula is SRK formula, which is stated as P equals to A minus 0.9K minus 2.5 AH. IOL formulae are are of 4 generations, first to fourth, and the need for the newer generation of IOL formula is to calculate IOL pass in special cases like high myopes, high hypermetropes, unusual biometries, and corneal ectasias to simplify IOL selection and to improve the refractive accuracy after the surgery. So there are some cases when IOL power calculation is challenging. For example, post-refractive surgeries, pediatric cataracts, aphakia, especially in SFIL calculation, then piggyback IOLs, then ICL implantation, and posterior segment pathologies like posterior staphyloma. So this is how what biometry is and how it is performed, and its application for IOL power calculation. Thank you.
Thank you, Dr. Gargi, for nice presentation and perfectly in time. So the topic is open for questions from the judges.
So Gargi, you mentioned about two things. I have two questions for you. The
Yes.
first question is, you talked about increasing gain in dense cataracts or in, when you have opacities and
Yes.
stuff.
Yes, ma'am.
Do you know of a situation where you need to decrease the gain? No? Okay. We'll move on to the next. In silicone oil filled IOLs, you want to decrease the gain.
Yes, ma'am, because
The
yes,
next
ma'am.
question. Okay. Next question is that you talked about 3 types of optical biometers. Do you know that there are more optical biometers available in today's day and age?
Yes,
You're
ma'am. There is
talking like
also
about 4 years ago. Today we are 4 years ahead of what you're talking.
yes, ma'am.
Do you know of any newer optical biometers?
Yes, ma'am. Pentacam is also there, wherein the
Pentacam is, one second, Pentacam is not an optical biometer.
but ma'am, we measure the space between corneal endothelium and the anterior surface of the lens. So that is what measuring of anterior chamber depth is also one of the parameters wherein.
And what are the other parameters that you can also measure? Is the posterior corneal surface as important?
Ma'am, actually, I couldn't hear you. Hello.
Is the posterior corneal surface or curvature also important?
Yes, ma'am.
Yes. What is the position of the lens also important?
Yes, ma'am.
So all these are also parameters which you will look at.
Yes, ma'am.
We talked about 3 very basic parameters, but today biometry has gone much ahead. So
Yes.
we are using newer and newer parameters which are helping us to get closer and closer to emetropia.
Yes, ma'am.
Correct?
Yes, ma'am.
Okay. Thank you.
Thank you, ma'am.
So can we go for next presentation?
Yes.
Yes. Dr. Aditi, please share your screen.
Sir, am I audible?
Ready for presentation?
Yes, sir.
Are you ready?
Yes, sir.
So timer. Start.
A very good afternoon to everyone. My topic for today's presentation is treatment of neovascular glaucoma. What is the basic introduction? It is a kind of a secondary glaucoma associated with fibrovascular proliferation in the anterior chamber angle. Other names for it are thrombotic and rubiotic. The main common etiologies for the same are proliferative diabetic retinopathy, central retinal vein occlusion, and ocular ischemic syndrome. There are 4 main stages which are prerequisites for NVG. That is pre-rubiotic stage, pre-glaucoma, open angle neovascular glaucoma, and closed angle neovascular glaucoma. Weiss and Gold classification is very commonly used for grading the NVI and the NBA. So here we can see the arborizing pattern which is seen in gonioscopy. My topic mainly focuses on the treatment. So treatment classifies investigation as well as the management, which can be medical and surgical management. In the investigation, we'll be going ahead with systemic investigations and ocular investigation. In systemic, we have blood pressure has to be examined, the blood sugar levels, fasting and postprandial, lipid profile, renal profile, and carotid Doppler. And ocular investigations, electroretinogram, iris angiography, fundus fluorescein angiography, fundus photo, and B-scan should be done. These are the images of the various investigation which we should be going ahead with. So first, primarily slit lamp examination is always done, wherein the neovascularization is seen on the peripupillary area, followed by the neovascularization, which is seen on the fundus photograph, and the ischemic area, which is seen in the OCT. On the right-hand side, we have the ASOCT photos and the images as well, which basically enhances the peripupillary dilatation and the tuft of vessels which can be seen. And B-scan can be done as well. Fundus photos of the most common causes of NVG are proliferative diabetic retinopathy, CRVO, and ocular ischemic syndrome. How will we manage? First is always the prevention and the medical management. Medical management constitutes aqueous suppressants, which are carbonic anhydrase inhibitors, topical beta blockers, and alpha-2 agonists. Mydriatics such as atropine, hyperosmotic agents such as mannitol can be given. Administration of cycloplegics and steroids, and anti-angiogenic factors such as anti-VEGF, bevacizumab should be given intravitreal or even intracameral in order to decrease the angiogenesis. Prophylactic therapy should be the main goal, wherein PRP or pan-arterial photocoagulation is very commonly preferred. This is preferred in three main settings, such as your diabetes mellitus, CRVO, and ocular ischemic syndrome. And ideally, it is effective in case of a pre-rubeosis stage. Gonio-photocoagulation, wherein the application of the argon laser is directly done at the angle of the anterior chamber, and thereby it helps in preventing the progression of the disease. Surgical management, there are cyclodestructive procedures which can be done, diode laser photocoagulation and transclerin NDI. Also, filtering surgeries are done, and as an adjuvant, 5% of 5-fluorouracil can also be used. Tube shunt surgeries are also there, where it can be placed in the ciliary sulcus. That is preferred more commonly. And cyclodestructive procedures is done in settings wherein 180-degree, their quadrant-wise sittings are done. This is in order to convert a painful eye into a painless eye with no PL or no perception. This is a summarization or an approach of how the individual should be approached with an NBI. The basic concept of medical history, gonioscopy has to be done, and localizing the cause. It can be unilateral or bilateral causes. In case there's vascularization in the angle, and depending upon the intraocular pressure, if the IOP is elevated or normal, how will we go about? And if in case it is elevated, our primary should be to decrease the IOP, followed by anti-VEGF, and then do PRP. And carotid Doppler should also be done in such individuals. Fundus photo and fundus angiography should be done as well. Thank you so much.
Thank you, Dr. Aditi, for a nice presentation and in-time completion. So this topic is now open for the questions from judges.
Since I'm asking all the questions, I want somebody else to ask questions now.
Dr. Sarad.
Yeah, I think whatever she has presented, it's quite very well narrated. Just a small question, and
yes, sir.
Are you aware of which implants work well in neovascular glaucoma?
So there are non-valved and valved implants. Generally, there's a Ahmed implant, which is of newer modality, which can be used. So there are also tube shunt devices which are there, which can be used in such individuals who have NVG.
So presently, do you know that trabeculectomies with anti-VEGF given prior are basically now the favored mode of treatment in NVG as compared to tube shunts? Tube shunts are no longer used as they used to use as first line of treatment in NVGs any longer.
Yes, ma'am.
And how long does the effect of an anti-VEGF last?
Ma'am, approximately it'll have to we'll have to assess the patient again at least per monthly. We'll have to evaluate the patient, and depending upon the posterior segment pathology.
Can I interrupt you? I said how long will the effect of the anti-VEGF last? Which means how early after the anti-VEGF will you do your surgery?
At least for a period of 1 to 3 months, we'll have to halt and we'll have to assess if the progression is happening or no. Followed by that, even if the patient's compliance also matters in this kind of case. So we'll have to evaluate in toto and then see what we can do with. We'll have to measure all the parameters. The intraocular pressure has to be checked.
1 second. To correct you, we are giving anti-VEGFs in these patients because you want the vascularization to be minimum so that your trabeculectomy will be successful.
Correct.
Okay?
We are
You
giving it as
can't
an
wait for
adjuvant.
3 months because that is not how long your anti-VEGF will give you avascularity. You have to operate at least within 2 weeks of you having given your
Within 3 weeks
anti-VEGF.
of
You can't wait for 3 months.
Yes, ma'am.
You will land up in a problem.
Yes,
And
ma'am.
secondly, you told us that there are so many causes of NVG. But have
Correct.
you thought about what is the basic pathology that causes vascularization on your vascularization?
Retinal hypoxia is one of the main etiology.
It should have been mentioned primarily in your slides.
Yes.
So that is the one thing that you didn't mention anywhere.
Yes, ma'am. Retinal hypoxia is one of the main causes.
Very good. Very good.
Yes. Yeah. Thank you so much, ma'am.
Very good.
Thank
you, ma'am.
So now we'll go to the next presentation. Dr. Samiksha, please share your screen. Screen. Presentation. Share the screen.
I think you can also contact Dr. Pratiksha because she has missed a presentation.
Yes.
Yes.
Are you ready?
Good afternoon.
Ready? Just
Yeah.
1 minute. Timer, please. Start.
Yeah. Good afternoon, sir. My today's topic for presentation is fungal keratitis. As we know, fungal keratitis is one of the most serious ocular infection and has catastrophic effect on the vision. Looking at the epidemiology, it is more common in tropical countries compared to the temperate countries. In North India, aspergillus is the most common cause, and in South, fusarium is the most common cause. It is most common in monsoon and early winter. This is the classification of fungi, of which yeast and filamentous are the most common causes, and of the filamentous fungi, the monolaceous, that is aspergillus and fusarium, are the most common cause. With vegetative trauma, foreign body, topical steroid use, diabetes mellitus, and other immunocompromised situations, coexisting other microbial keratitis and contact lens uses are the risk factor. And its pathogenesis is that the fungi become adhered to the cornea epithelium, and the hyphae starts penetrating in the stroma and starts releasing mycotoxin and fungal antigen and proteolytic enzyme. The host then responds accordingly by releasing neutrophils and immunological cascade. Compared to other microbial flora, fungi is a bit larger in size, so for the host to respond accordingly, it takes a bit longer time as compared to other microbial flora. This explains why symptoms are lesser as compared to signs. The most remarkable sign is feathery margins. The other signs are dense infiltrate, multifocal lesion, satellite lesion, dry texture, collar button, raised slough, pigment deposit, endothelial plaque, immune ring, neovascularization, and hypopyon. Diagnosis can be made by corneal scraping. Cornea is scraped using Kimura spatula or 15 number blade under the slit lamp examination, and the edge and the base of the ulcer are scraped, and it is stained using 10% KOH, gram stain, gomerimethamine silver stain, and is observed under light microscopy. It can also be stained with califlocker white staining and visualized under fluorescent microscopy, of which 10% KOH has 99% sensitivity. Fungi can be cultured in Sabovo dextrosaga and potato dextrosaga. Initial growth occurs within 72 hours, and we have to wait for at least 7 days for the culture to be negative. Other diagnostic modalities are polymerase chain reaction and confocal microscopy. The image given here shows the hyphae in the confocal microscopy. Treatment can be topical antifungal 5% atomycin 1 hourly at daytime and 2 hourly at bedtime, and it should be tapered accordingly after 4 to 7 days. And if there is no effect or it gets worsens, 0.15% amphotericin B or 1% voriconazole can be added. According to Mudpond trial, topical atomycin is more effective than topical voriconazole. Systemic antifungals can be used in large ulcers, severe dip keratitis, scleritis, and N. ophthalmitis. We have to keep in mind that these antifungals are hepatotoxic, so we have to monitor liver function test every 2 weekly. According to MUD2 trial, there is no benefit in adding oral voriconazole to topical antifungal agents. Targeted drug delivery by intracameral and intrastomal injections. Although RCTs have shown no added benefits of adjuvant intrastomal antifungal in the treatment, though intracameral amphotericin B has some benefits. So the TST protocol is topical, systemic, and targeted therapy. The first line is topical netamycin 5%, addition of oral ketoconazole or voriconazole in severe ulcers. In second line is addition of topical voriconazole 1%. Third line is intrastromal and intracameral antifungal. Fourth line is therapeutic keratoplasty. If there is thinning or desmatocele, bandage contact lens can be used. If perforation is less than 2 mm, cyanoacrylate glue is used, and if perforation is more than 2 mm, therapeutic keratoplasty is done. Some recent advances shows that topical capsofungin can be used. Means it is still the research is ongoing. And photoactivated chromophobe corneal collagen cross-linking has been suggested to improve healing and inhibit corneal melting, though it has no any benefit in fungal keratitis. Thank you.
Thank you, Dr. Samiksha, for completing in time and nice presentation. The topic is open for questions.
Samiksha, can you hear me?
Yes, sir.
Samiksha, you said that for the purpose of diagnosis, you will do a corneal scraping. Would you do a corneal scraping only for diagnostic purpose, or there is any other way it can help you?
So corneal scraping, if we scrape it, the oral antifungal topically, it has more effect if we scrape it thoroughly. So it has therapeutic effect also.
Okay. Good.
I think in between there was difficulty in availability of M4B. So
Sorry, sir.
I think caspofungin came in the picture probably because of the difficulty in availability of M4B.
Yeah.
And also I think there was some comment about liposomal M4B. Especially for fungal cases.
I don't have any idea right now. I can't recollect that.
I think the issue is that the liposomal one is very costly.
Yeah. The
And
cost effect.
this M4B is available. Now it's available very.
Okay, shall we move next to the next?
Yes.
Thank you, sir.
Please stop sharing. Samiksha.
Yes.
Dr. Nikita, please share your screen. Yeah. Ready to present? Ready to present?
Sir? Yes, sir.
Yes.
I'm Dr. Nikita. I'll be presenting anti-VEGF in ARMD. ARMD is a chronic progressive degenerative disorder of macula, which causes severe vision loss in more than 55 years of age group. As we can see here, there is loss of central vision. There are two types of ARMD, dry or non-exudative ARMD and wet or exudative ARMD. In dry ARMD, there is lipid deposition between Brooks membrane and the RPE. And in wet ARMD, new vessels from choriocapillaries grow inwards through break in Brooks membrane. This is a slide of dry ARMD. We can see drusen's. In wet ARMD, there is subretinal hemorrhage. This is OCT image showing subretinal hemorrhage. This is in early phase classic CNV, and this is profuse leakage in late phase. Now moving on to anti-VEGF therapy. These are the various agents we use in anti-VEGF. First drug introduced in 2004 was pegaptinib. In 2005, bevacizumab was introduced, and in 2006, ranibizumab. In 2011, aflibercept was introduced. VEGF-A has receptors on endothelial cell surface. It stimulates angiogenesis and increase vascular permeability. Anti-VEGF drugs, they act on VEGF receptors. Now anti-VEGF comparative study. First drug is bevacizumab, also known as avastin. It is fully humanized monoclonal antibody. It binds to all forms of VEGF-A. Its molecular weight is 147 kilodaltons, and it is injected as 1.25 milligram in 0.05 ml. It is not FDA approved.
It is only used in metastatic colorectal cancer. Ranibizumab is also known as Lucentis. It is an antibody fragment. It acts on all forms of VEGF-A. Its molecular weight is 48 kilodaltons and it is injected as 0.5 milligram in 0.05 ml. The pegatinib is also known as Macugen. It is an aptamer. It is selective VEGF binding agent. It binds only to VEGF A165. Its dose is 0.3 milligram in yes, ma'am.
You can continue your presentation.
It is injected as 0.3 milligram in 90 microliter. Its molecular weight is 50 kilodaltons. In the aflibercept, also known as Eylea, it is a recombinant fusion protein. It acts on all forms of VEGF-A, also VEGF-B, and placental inhibiting growth factor. Dose is 2 milligram in 0.05 ml. Its molecular weight is 97 to 115 kilodaltons. Then the newer drug is brolucizumab. It is also known as BuView. It is humanized single-chain variable fragment antibody. It binds to all forms of VEGF-A. Its molecular weight is 26 kilodaltons, so we can inject more drug in that is 6 milligram in 0.05 ml. These are different trials used for these anti-VEGF drugs. For bevacizumab, ABC trial. For ranibizumab, Marina, Anchor, Pyre, Pronto, and Sustain trials. And CAT study was a comparison between ranibizumab and bevacizumab. Anti-VEGF are injected under all aseptic precautions. Different treatment regimens are monthly injections, PRN regime, Pronto regime, and treat and observe, and treat and extend. Disadvantages of anti-VEGF. There is a need for repeated injections. The compliance to treatment is poor. Infectious endophthalmitis can also occur, and rheumatogenic retinal detachment. Thank you.
Thank you for the presentation. Now topic is open for the questions from judges.
So Nikita, do you think there is any role of lasers in this current era of anti-VEGFs?
Yes, sir.
Role of lasers in AMD.
Sir,
you can just tell me specific indications where you would like to do laser, especially in cases of AMD.
sir, where there is a extrafoveal involvement.
Okay. But there also, I mean, it's better to give anti-VEGFs, and if at all the membrane is too much heavily dependent on anti-VEGF injections, then you can add on some laser to extrafoveal CNVs. But specific indications would be a RAP lesion, that is retinal angiomatous proliferation, or second indication is polypoidal choroidal vasculopathy. So though it's a different entity, but many times these cases are considered as patients of age-related macular degeneration. So in these cases, you can do a direct focal laser to these lesions.
Okay, sir.
Okay. Can we go to next, last presentation?
Yeah, we can go ahead, sir.
So Dr. Pratiksha, sorry for keeping you waiting, but we wanted an uninterrupted presentation, and please start your presentation when ready. Yes. Timer, please.
So today's topic is congenital ptosis.
Please go on a slideshow mode.
Slideshow. We are not seeing timer. Slideshow.
Yeah, full screen.
Slideshow. Full screen.
Full screen.
Is it moving, na sir?
No.
We want you to go on slideshow, beta.
Full screen.
Please use the slideshow mode. You go on the top, or there is an icon at the bottom.
Where you can see decrease, increase, just there there is an icon which will show you slideshow right at the bottom.
Yes, ma'am.
Yeah,
Yeah,
that's
that
it.
one.
Click on that.
Is it? Yeah, I clicked.
No, it's not slideshow still. Yeah, now click on it.
Is it okay?
No.
No, no, no.
F8 पण होता ना? Press F8.
Yes, ma'am. Is it okay?
No.
Okay.
No, it is still not on slideshow.
Are you pressing F8? Go up on your laptop or your whatever computer you're using and go to F8.
Okay, ma'am.
I think she has a problem with the net connectivity.
Okay, okay. Okay, so then I think we will time her.
Yes, we will keep a timer and she will present on the small screen.
Yeah, that's right.
Dr. Pratiksha, can you reshare your screen? Yeah. Yeah, you can start the presentation in the same
mode.
Yes. And if the admin can start the timer, please.
Yes.
Dr. Pratiksha, please start.
Start. Hello, Pratiksha. Please start the presentation.
Can you hear us, Dr. Pratiksha?
Yes, go ahead.
I think there
Hello.
is a problem with her
Yes.
net connection.
Am I audible, sir?
Yeah, you're audible.
Yes, now audible. Please start the presentation. We'll make again.
Am I audible?
You're not very nicely audible, but
Voice
you're
is not.
audible. Your
Voice
voice
is
is
not clear.
breaking.
The slide is moving.
The slide is moving.
Okay, ma'am. Good afternoon, everyone.
Reset timer, please. Reset timer. Start. Pratiksha, please start.
Today's topic is congenital ptosis. I'm covering this topic under this heading. So what is ptosis? It is drooping of one or both upper eyelids with eyes in primary position. As we know, congenital means present since ptosis is amblyopia. There are various types of congenital ptosis.
Please
Simple.
move your slide.
Slides are not changed. You have to change the slide.
Now, sir? Is it moving?
Yes. Like that you move and go on telling.
Okay. There are various types of congenital ptosis. Simple and other are complicated ptosis. The examination is very much important. We have to measure MRD1, that is the distance between upper eyelid margin and corneal reflex by the pain light. We have to measure PFH, that is palpebral fissure height, that is distance between upper and lower eyelid margin at the pupillary plane. Levator function measurement is very much important. We have to measure it by asking patient to look in the extreme down gaze and then look in extreme up gaze, and we have to measure the distance between them. We have to take precaution that we have to block frontalis action by keeping thumb here. There are other points also, like Bell's phenomena, tear film, pupil, extraocular movements. These things also we have to examine. So what is the cause of simple congenital ptosis? Because of dysgenesis of levator muscle, the simple congenital ptosis has occurred. It is unilateral or bilateral. Patient is presented as absent lead crease, and there is a lead-like sign is present in down gaze, which is very important peculiar feature, differentiating feature from acquired ptosis. So when to operate these patients? Mostly we have to operate these before school years, or if there is a severe cases, we have to operate it earlier to prevent amblyopia. So how to manage this simple congenital ptosis? Firstly, we have to categorize it into good, moderate to good LPS action or poor LPS action. If it is a good, that is more than equal to 5 mm, we can do LPS placation or resection. In this surgery, we're going to shorten the levator muscle and suture it to tarsus. It has two approaches, like anterior and posterior, uh, through skin or conjunctiva. If the levator action is poor, we have to do frontalis sling. That is, we are making connection between frontalis muscle and eyelid with the help of subcutaneous sling, which elevates the eyelid. There are two types of sling, that is autogenous and non-autogenous. Depending on, there are types like Fox Pentagon surgery and Crawford surgery. Frontalis flap surgery. In this case, we are going to suture the frontalis muscle to tarsus. So there are some complicated types of congenital ptosis, that is BPAS, which is autosomal dominant and bilateral, the bro suspension or frontalis sling surgery. And this is the most common association of this disorder is female infertility. This second image is showing the post-operative picture after frontalis sling surgery. Marcus-Gunn jaw winking syndrome. In this, there is a misdirection of branch of mandibular division of fifth cranial nerve to the levator muscle. In this case, there is a retraction of eyelid after moment of jaw to the opposite side, or sucking or chewing, or the opening of the mouth, as shown in video. Monocular elevation deficit. In this case, there is a ptosis and hypotropia is present. LPS and superior rectus are affected. Mainly, frontalis sling surgery is the surgery of choice. If the squint is present, we have to operate it first and then go ahead with the ptosis surgery. In this picture, we can see there is a limitation of elevation of right eye. Other movements are normal. Other type of ptosis is congenital fibrosis of extraocular muscles. In this case, it is also autosomal dominant, and there is limitation of ocular motility, and eyes are fixed to the downward direction. Another type is the third nerve palsy. In this case, the eye is
Sorry to interrupt. You have crossed the time limit. Cross the time limit.
Yes, sir. Down and out. In this case, there is a right eye third nerve palsy. Only the right eye abduction is present in right eye. The movements are limited. So what are the important points? There are various types of congenital ptosis, and we have to do refractive error assessment in each congenital ptosis type. As there is a...
I think considering the time constraints, I think you'll have to stop here.
Yes, sir. Thank you.
Stop sharing, and if queries are there, please answer.
So just one question for you.
Yes, sir.
If the parents are not willing for surgery for a specific kid,
yes,
is there any other option you can offer to the parents?
Sir, we can give crutch glasses.
Yeah, right. Okay, thank you.
Thank you so much.
Hello. So our all 14 candidates have presented.